give credit to Dr. Whitaker for helping out with this lecture. And so the objectives for today, so we're going to, for the first 10, 15 minutes or so, we're going to hit on some key aspects related to the history and physical that are pertinent to the exam, and then afterwards give some visual cases, and then discuss key points related to different ocular injuries that are associated with each one, and then when to consult ophthalmology towards the end. So eye injuries, very common, occur about 70,000 times per year in pediatrics. It tends to occur, one of the more common mechanisms tends to be sports related, so eye protective wear is very important in those scenarios. And it is one of the leading causes of unilateral blindness in the US, and it tends to occur more commonly in boys than girls. So history, so what are the key aspects to get out of the history? So number one is understanding what their baseline is whenever they do come in. So do they wear corrective eyewear? Do they have underlying ocular issues or systemic disease such as sickle cell, bleeding disorders? Do they have a history of eye surgeries in the past? Do they have a history of strabismus? Do they have a history of asymmetry of the pupils at baseline? And oftentimes families may not know, but anisocoria, where you have different sizes of the pupils, is very important to understand prior to. And sometimes you can compare previous pictures, so on their phones, where you zoom in and see, oh, is this kind of their normal from before, or is this different? And then also with any injuries that involve lacerations or anything like that, knowing their tetanus status and whether you need to update that or not. So part of the history, so a lot of these ocular injuries, you'll find common themes related to symptoms. So eye pain, photophobia might be associated with it, tearing, eye redness. But hopefully whenever we discuss the ocular injuries in each one, we will depict some key points that will help distinguish between the ocular injuries that you would be concerned about. You could also have asymmetry associated on exam, change in visual acuity, which is very important, especially ophthalmology will also ask for that, a vision screen to be done when these kiddos present. The sensation that a foreign body is there, or the history that something got into the eye or something injured the eye. And then the mechanism is also very important. So how hard of a mechanism was it? The speed, was it a blunt trauma injury? Was it a penetrating injury? Was it sharp? Things of that. And then also the timing, especially with chemical substances, you want to know how long ago did it occur. And even with certain injuries, you want to know how long ago did it occur. So the physical exam, so like I mentioned earlier, you will see common scenarios, but obviously at first glance you want to see the anterior surface of the eye. You'll typically often see there's bruising, swelling, maybe even bleeding, but we'll talk about some other things as well as we go through. So externally, in addition to your external exam, which I already mentioned, you also want to take a look at the lids on the inside surface. So looking at the conjunctiva that are behind the eyelid specifically, and as well overlying the front of the eye on the inside as well. So looking specifically at the palpebral conjunctiva, which is just under the eyelid, as well as the bulbar conjunctiva, which is as well just overlying that scleral surface as well. The pupillary reactions, so are they equal, are they reactive to light? And then we'll get into a little bit more details about that specifically. And then is there any restriction or is there full range of motion of their extraocular muscles on exam? The visual acuity, like we mentioned, very important. And then I know a lot of people aren't comfortable with this. I myself am not super comfortable with doing a fundoscopic exam, but looking in the back of the eye, the more you do it, the better you get at it. But looking in the back of the eye for any hemorrhaging, any papilledema, any swelling, things of that nature as well. And is there a red reflex present? Others as indicated, so checking for fortunately enough, we do have a device to check for intraocular pressure here, thanks to Erin and her getting that available for us here in the ER. And then also doing visual fields, and then if we need to do a slit lamp exam for magnification of the eye, ophthalmology is very obviously comfortable doing that. And I know a lot of the ER trained physicians in the adult world are very comfortable with using the slit lamp as well. So going into specifics for each physical exam, so inspecting the eyelids, this is one technique that you can use to look at the palpebral conjunctiva. More specifically for the upper eyelid, for the lower eyelid, just putting some gentle traction on the cheek itself can help you visualize the palpebral and bulbar conjunctiva. But with the upper eyelid, what you want to do is use a Q-tip, and again, you're not putting necessarily pressure on the globe, but you're engaging the skin with the Q-tip, and then turning it clockwise to engage that skin, and that will indirectly lift up the eyelid. You can then grab the eyelashes and pull up while pushing down on the Q-tip, and that'll help to evert the eyelid to better visualize that area for the upper eyelid. So the pupils, so again, outside of looking at asymmetry as well as reactivity on both sides, you also have, so normal healthy kiddos and adults have an afferent pupillary reflex, which is an arc reflex associated through the midbrain. And so when you have pupillary constriction of one side, it is normal for the other side to also constrict. And so a Marcus gun pupil is an abnormal pupil when you do have an afferent pupillary defect, to where when you perform the swinging light test from one side to the other, normal, you should have minimal to no change of that miosis and constriction of the pupil. It's whenever you go to the abnormal side or the defect to where you'll see dilation of both pupils, if that makes sense. And those are more associated with, again, traumatic neuropathies, so related to either pressure or ischemia or things of that nature, where you'll tend to see this scenario. So the red reflex, so that as well you should be able to see, again, with the lights dimmed, and then also looking through the ophthalmoscope. And so this, if there's anything that's obscuring it from a surface standpoint or on the inside of the eye, either due to hemorrhage, due to cataracts, due to misalignment of the globe or displacement of the globe, these are different reasons why you might see a dull or an absent red reflex compared to the other side. So it's something that you also want to check and look for as well. The fundoscopic exam, like I alluded to before, so you can have with trauma unilateral papilledema. So you will see obscured disc margins, you will see swelling, in addition to some of the hemorrhages in the posterior part of the eye as well. Visual acuity, so again, very important. Typically at age 3 is when you start seeing the charts, the visual charts that you could use in pediatric patients. And what is more difficult is the younger population, so infants and toddlers, again, because of cooperation, obviously, but there's no typical gold standard. But what will help at a kind of, just to get a quick glance of part of their visual acuity is whether they're able to fix and focus on an object. So typically around 2 to 3 months of age, they should be able to focus centrally on an object, so a bright toy or a face, and be able to follow it to some degree at 2 to 3 months. At 6 months, a 6-month-old should be able to follow in all visual fields an object or a bright object. So again, I don't know how often we're going to use this in terms of, but a general rule of thumb is if there's a central steady focus, then roughly the visual acuity is 20/40. If it's unsteady, it's 20/100, and then if it's just wandering, then you're more concerned about an ocular injury in that scenario. And then like I mentioned, the preschool and the school age, you can start doing the visual charts at 3 years of age. There's other tests that you could also do. So if kiddos that normally wear glasses or normally wear contacts don't have those with them and you're worried about doing a vision screen, one thing that you can do is use a pinhole test, and that'll help correct the refractive error that they have at baseline. And that'll help you distinguish between, okay, is this really a decrease in their visual acuity, or is it just their baseline refractive error? And so you could use a pre-made device as you see there. It's just, or you could get an 18 gauge needle, and poke a bunch of holes in a index card or into a rigid eye shield, and that'll help with the refractive error. So what that helps is reduce extra light that doesn't need to be bent. It'll just allow light to enter perpendicular to help with that refractive error. And so it roughly adjusts it to about 20/30. I tried it last night and it actually works. And so I was like, oh, I can read better with it. Anyway, so it does work and it does help. And then other things, so if there's significant amount of swelling to where you can't get a great eye exam, one thing that you can do as well is do test for light perception. And this is with or without direction. So is it bright, is it dim, or do they not see any light at all? And then also with the direction, do you see the light moving up, down, right, even with the eyelid that's closed? For those that are visually impaired, understanding what their baseline is, so are they more nearsighted? Can they only see hand motion? Can they only do fingers? That kind of helps too from a visual screen standpoint as well. All right, so we'll take just a brief 1-minute break, and then we'll go into name the ocular injuries in the cases themselves. So, or a 30-second break. This next portion, it'll be, so like I mentioned, visual cases, followed by a board review question after each one. So if one of you don't mind reading the board case question, that'd be great. Thanks. I hope you like the last line. That's the last line. I thought it was cool. Maybe not. All right, so we'll move on. All right, so this kid comes in worried about an injury. What are you worried about, or name that injury and exam? What is it that you see? And this is what you see on exam. What is it? Anyone? Corneal abrasion, yeah, exactly. And so it is over the visual axis, pretty moderate size corneal abrasion. You could also have conjunctival abrasions as well. But we'll kind of get into some of those details. So with corneal abrasions, like I mentioned earlier, you can see tearing, eye redness, photophobia, sensitivity with light, not wanting to open their eye. But you always want to check for, especially if there's a history, for retained foreign body. So looking under the eyelids, both upper and lower, looking in the fornices. And then something that you also note with some of these exams that will help to get a better exam if they're not cooperating very well is using topical anesthetics. So tetracaine drops is what we tend to use here. And that takes about 15 seconds to work. And so if it works and they feel more comfortable, then that's more reassuring that it's a surface injury. But if it doesn't work and they continue to have significant pain even after the tetracaine, then you worry about, could this be a deeper injury that I need to investigate further or have ophthalmology come and see. So with corneal abrasions, so most of them, especially if they're small, will heal on their own without any treatments, antibiotics, or anything at all. But if they are larger, that's when people tend to use more topical antibiotics, and the recommendation is to use topical antibiotics, typically erythromycin, and an ointment is preferred. One, it helps with lubrication, and the other is it is less frequently applied than eye drops itself. But it also helps with disrupting less the new epithelium that tends to regenerate compared to eye drops, the ointment does. So that helps as well. What you want to avoid are topical steroids, so steroids that are in ophthalmic antibiotics that will only delay wound healing, as well as anesthetics also tend to delay wound healing as well. And you worry about the patient at home, if you were to prescribe anesthetics to go home with, causing further damage or further injury because they can't feel anything that's going on in their eye. The other things that you could do for pain control are your systemic medications, so Motrin, Tylenol. Talking to ophthalmology, sometimes they will recommend ophthalmic solutions, NSAID specifically, so diclofenac, ketorolac, and then also cyclopentolate, which is a mydriatic, which helps inhibit the myotic constriction and myotic response and that ciliary spasm. And so that will help from a pain control standpoint as well, which they will sometimes recommend. For larger abrasions, especially ones that are over the visual axis, the recommendation is to use a patch. It's not recommended for smaller abrasions, but if it's typically over half involving the cornea, then that's where you would use a patch for comfort and for pain control as well. So reasons to talk to ophthalmology early on. So definitely if it's over the visual access, or have them see opto sooner rather than later. Over the visual access, a large abrasion. If they wear contacts, one thing you want to stress is don't use your contacts. Avoid using it until you see ophthalmology, until your abrasion completely heals and goes away, and you finish the antibiotics as well, meeting all those 3 requirements. And you want to cover for anti-pseudomonal coverage. So typically you'll use a fluoroquinolone eye drop in those certain scenarios to cover for that as well. And then obviously if it's not improving, if it's been a few days, or if there's any discharge associated with it. So exactly what he said. So whenever they're lying flat, just pull a ton of drops on the medial part of the eye. And then if they don't open it themselves, what you could also do is just gently apply traction to the lower cheek, and that'll help to open up the eyelids, and then the tetracaine will get onto the surface there. So does anybody want to read this question? So yeah, consult ophthalmology. So that's the theory.
I know, I was going to say that.
Well, it takes about 15 seconds, so it should work. Exactly. So tetracaine typically works after about 15 seconds, so you definitely should see a very quick improvement in terms of their exam and cooperation associated with it. And so the theoretic increase of ketamine, I think, so the dose typically has been more than 1.5 mg per kg, where you see a more theoretical increase of intraocular pressure. So I think in general, people will still, and talking to Winnie, even talking to ophthalmology, you still will use ketamine to sedate kids if you do need a better exam. But with the tetracaine drops, it tends to be at a lower dose than you would a typical sedation for something that takes longer. All right, next case. What are you worried about with this? And this, no. So using the fluorescein exam, this is what you see. Yeah, so you'd be worried about a foreign body, exactly. So it's the classic vertical line abrasions, so you would be worried about something still in the eye, specifically under the eyelid, like they said, just as he's opening and closing is causing further injury from an abrasion standpoint. So with foreign bodies, so again, you want to thoroughly explore both behind the eyelids, in the fornices, as well as overlying the eye. So you want to evert it, and we talked about the outward traction on the lower eyelid and the cheek. So there's different ways to remove foreign bodies. So if it's obvious and you could see it on exam, then you could use a wet cotton swab or a gauze to be able to gently remove it that way. But if there's suspected but you don't see it, so you're worried about sand in the eye or something along the eyelids that's not clearly visible, you could do saline irrigation to help get that out as well. The other things that you could also do is use a slit lamp for magnification. And then in reading, it mentioned that you could also use a 25 gauge needle, which I have seen done once while opto was doing a slit lamp exam. But that just makes me nervous, with especially a kid who you have to make sure is definitely cooperative and isn't going to move whenever you're doing that. And then obviously if it's embedded, you're getting ophthalmology to come in to remove that. So using the needle to remove the foreign body, Yep. And then if you have a metallic foreign body, it is normal, or it can be expected to have rust on the eye, and so it may just be a rust stain, and that itself will eventually resolve on its own without any issues. And then key point, you always want to re-examine the eye after the foreign body is removed, just to make sure there are no abrasions, and if there is, to treat them appropriately. If you are worried about a penetrating foreign body or an intraocular foreign body, one thing, and especially if it's metallic, you want to avoid MRI associated with that. But otherwise, you can do, if it is on the surface that you're worried about, you could do an ocular ultrasound if you're comfortable, or just getting a CT to look for, obviously, the intraocular one. So anybody want to read this question? So evert the eyelids. Again, the anesthetic drops will help to facilitate the exam, but never want to be prescribed. And then steroids, eye patching, not indicated. And then you can see a dendritic pattern with herpes, but in this clinical scenario, it's not necessary. So chemical burns. So it's very important with chemical burns to assess both eyes. One might be worse than the other, so that's why it's always important to check the other ones. And then this is the litmus paper that you can check for the pH. So it's very important to check the pH before treatment. after treatment, and then about 10 to 20 minutes after you're done with treatment, which we'll get to here in a little bit. And the substances, so alkaline substances tend to be much more severe compared to acidic ones. And the reason for that is alkaline substances cause further penetration, deeper penetration, causing further injury, as opposed to acidic ones, which tend to coagulate with surface proteins, thence causing a barrier to prevent further penetration or further injury related to that. And so specific alkaline substances outside of ones that we'll get into, your drain cleaners or oven cleaners, things of that nature. You can also see chemical burns, something to keep in mind with airbag deployments. So with the combustion, you can have an alkaline substance that is produced in that mechanism, and as well certain fireworks that have aluminum hydroxide or magnesium hydroxide, such as sparklers or flares, you can see chemical burns of the eyes associated with that as well. So just something to keep in mind. So treatment is irrigation, irrigation, irrigation. So parents can start this at home, putting the eye under running water. But when they get here, you try to treat as early as possible with irrigation. And then again, topical anesthetics will help with not only the exam, but also if you're going to apply the Morgan lens, which this essentially just works like a big eye contact. You put gentle traction on the lower part of the eyelid, put it in that way, and then lift the upper one to get it over. And then this just helps with connection to an IV saline bag to help irrigate the eye rather than you having to manually irrigate it because the recommendation is to irrigate for at minimum 20 to 30 minutes and at minimum 1 to 2 liters of normal saline or LR before reassessing the eye. The pH, so normal eye pH, can range anywhere from 6.5 to 7.5. So shooting for a goal of 7.4 with the litmus paper is one of your end goals for eye irrigation. The very important key whenever you are checking for the pH, again, before irrigation, after irrigation, you want to wait several minutes before you test the pH because otherwise you're just testing the normal saline, which could range anywhere from 4.5 to 7, depending on the manufacturer. So you want to wait several minutes after the irrigation before you test it. And then you want to reassess it again 10 to 20 minutes later and make sure it's still stable. So when to consult ophthalmology, so even after treatment and irrigation, if they're having persistent pain, if they have any associated corneal lesions, or if they have decreased visual acuity, then that would be one that would have closer follow-up with ophthalmology. So these are some of the common substances, both alkaline and acidic. So swimming pool cleaner can be either alkaline or acidic, and then some of your common alkaline substances are the oven cleaner, drain cleaners. Bleach as well, something to keep in mind is household bleach is obviously much less potent compared to industrial bleach, but that's also a key question to ask. Typically it is going to be the just regular household bleach, but the industrial one can be have a significantly higher percent concentration, up to 15%. Okay. A lot of these, good. So again, irrigating until afterwards, waiting several minutes, make sure the pH is less than 7.5. And then regardless of what the pH is at presentation, if there's so having eye pain, if there's caustic burn to the soft tissue skin around it, you're still going to irrigate that just because the cause of injury is still high on the list, suspicion for. And then if you don't use topical anesthetics, you can use pain resolution as a marker, but otherwise if you use it, then you can't use that as a marker to stop treatment. Okay? See this kid come in, you see that injury, what are you worried about, or what do you see?
It's a lid lac.
Yep, eyelid laceration. And so key factors to discuss with eyelid laceration. So there's a few different factors that you definitely want to rule out and think about whenever you see an eyelid laceration. So number one, is it full thickness? And so it's very common to have ocular injuries in association with eyelid lacerations. And so you also want to rule out, is there potential globe injury that I should be worried about? But also with full thickness, you want to check again the palpebral conjunctiva. So with everting the eyelid, like we talked about before, you want to make sure it's not through and through. The other thing that you also want to worry about is if you see adipose tissue, you're very concerned that there is a much deeper laceration because there is no fat in the upper eyelid at all. And so you are worried about injury to the orbital septum and you're seeing orbital fat and so that would be more significant and definitely would need to talk to ophthalmology about. Next is levator muscle. Is that intact? So that's specifically involving the upper eyelid itself, and it's typically in that midline portion there of the upper eyelid. So is there ptosis present? So when you have them look up with their gaze, is their eyelid asymmetric, or are they both able to move upward as you would appropriately see? And so if there's any ptosis, again, if you do see adipose tissue as well, then you would be worried about levator muscle injury associated with that. The medial third, so if it involves the inside of the eyelid, either both the upper or the lower eyelid, you have the tear drainage system that is associated there, so you worry about the lacrimal canaliculi. So if that is injured, that's definitely one that you want to talk to ophthalmology about, because if that is not repaired properly, you can have permanent tearing associated with that and further complications. So you definitely want to get them involved. And like Winnie was alluding to as well, other reasons that you would talk to ophthalmology about repairing or getting, again, facial plastics as well involved potentially is significant avulsions or flaps involving the eyelids, but as well the lid margins. So like she alluded to here, these lid margins need to be well approximated and treated appropriately by ophthalmology. Okay, here can be perfect. So again, the medial part affecting the tear drainage system, so you definitely want to get ophthalmology involved early on. And then the upper eyelid is where you'll see a levator muscle injury, not the lower eyelid. And then again, if you see fat prolapse or ptosis associated with that, you're worried about levator muscle injury. If sutures are required, or if you're going to close it with sutures, typically, so you can use nylon or non-absorbable suture, but in pediatrics, it's typically recommended to use fast-absorbing gut, again, to avoid having to remove the sutures later on. So that is something that you would think about. And then systemic antibiotics are typically only recommended when there's an animal bite or contaminated wounds associated with it. Then you would consider antibiotics in that standpoint. Okay, this is what you see on exam. Kiddo comes in, there's an eye injury. Yep, perfect. HyphemA. And so HyphemA, so with blunt trauma, you have bleeding in the anterior chamber of the eye, and so you can't see layering, and it typically starts from the bottom up. So you could see inferior layering. This is one that you definitely want to talk to ophthalmology about, because you are worried about other potential ocular injuries or elevated intraocular pressure. And so it's very important, and it can be subtle, so it's very important to do a thorough eye exam, because you can't have just a subtle layering of blood at the inferior aspect of the anterior chamber. So it's very important to get a thorough exam, especially with the right mechanism. Therapies, so you can give systemic medications. What you do want to avoid are NSAIDs because of the effect it has on platelet dysfunction, and so just causing further rebleeding, which is already a known complication associated with HyphemA. So you want to avoid NSAIDs, avoid Motrin, but you can place an eye shield, again, because they can have photophobia associated with it, so for comfort and pain relief. Rest, limit activity. Head of the bed elevated to 45 degrees. Again, this helps with the layering, to where if you lay them flat, it would just cover their eye and cause more angst rather than anything. And then just in discussion with ophthalmology, they may recommend mydriatics, medications, steroids, either topical or systemic, and then antifibrinolytics such as TXA or something of that nature. So most of the time, HyphemAs, especially if it's an isolated HyphemA, there's no other injuries or no concern for elevated intraocular pressure. They most will resorb on their own fully without any complications, and so they just need close follow-up with ophthalmology. But prior to that, you would get an ophtho evaluation just to make sure there is nothing else going on in these cases. But most do well and can go home.
My question was,
Yeah.
Admission for surgery.
Yeah, definitely. So the treatment is based on, and again, more so from an admission standpoint, like Sujik was alluding to, is based on the grading of HyphemAs. So less than a third is a grade 1, third to 40%, as you can see there's 2. Over half of the anterior chamber involvement is a grade 3. And typically at that stage or higher is one that you would definitely want to admit for observation as well as appropriate treatment. And then grade 4 is just the entire 8-ball eye. So admission, so at least a grade 3 or higher, you definitely want to admit. If it's complex, so elevated intraocular pressure or other ocular injuries that are associated with it, you definitely want to admit. If they do have an underlying bleeding disorder, sickle cell disease, hemophiliacs, etc., or if they're on Coumadin or any other medications that may lead to a coagulopathy, then that would be a reason as well. And if there's any concern for poor follow-up as well. The younger the age, again, because of cooperation, this kind of goes into poor follow-up, but younger the age, typically infants and things like that, you would also consider admission as well. Complications, so rebleeding is a significant complication, and the higher the grade gets, the more at risk you are of having a poor visual prognosis in terms of their acuity and their vision. And so it occurs up to 38% of the time with HyphemA, with this typical injury, and it typically occurs in the first 5 days after the initial injury. It can lead to, as you can see there, elevated intraocular pressures leading to acute glaucoma, as well as corneal staining of the eye. Kiddos that are at higher risk, like I mentioned, the higher the grade is, the more at risk you are of rebleeding. And then kiddos that have underlying bleeding disorders. So definitely sickle cell disease kiddos, because of the hypoxia, because of the sickling, because of the obstruction that is associated with that, that's where you would be even more worried about this complication. And even at a marginally elevated intraocular pressure compared to healthy kids, they could also get optic nerve injury or atrophy associated with it. So you are also worried about that as well. Okay. So place an eye shield over the left eye. Again, elevate the head of the bed. Dimming the lights will also help reduce some of that photophobia associated with it and pain associated with it. And again, avoid NSAIDs with HyphemAs because of the platelet dysfunction. And then we talked about, especially on boards, ketamine's not the answer, but we've talked about that. All right. What would you be worried, diagnosis-wise, if you saw this? And this is a clinical diagnosis. Well, not really a clinical diagnosis, but anyone? Uveitis, I heard. Yeah, traumatic iritis, exactly. And so the classic perilimbal injection and inflammation around the iris and around the eye, that's kind of classic associated with these. And these are typically a delayed presentation, so the initial injury occurred 1 to 3 days prior, and their exam after that or that same day could be essentially normal, no abrasion, no inflammation, nothing related to that, and then they end up getting this inflammation a day to 3 days later. And the classic is the characteristic physical finding is that inflammation perilimbal injection that you see, as well as photophobia that's significantly associated with this, similar to with that meiotic response and pupillary constriction. That's where they tend to get pain because you have inflammation in the anterior chamber of the eye. And this is when you definitely want to get ophthalmology involved, again, to rule out other injuries. The diagnosis is with a slit lamp exam, and in the anterior chamber with the aqueous humor, there is a low protein concentration, and so what ophthalmology will see is white blood cells in the anterior chamber, but also a protein flare is what they call it, a higher concentration of protein in that anterior chamber, in the aqueous humor. So treatment, so mydriatics help with this, cyclopentolate, topical steroids as well, that helps reduce the inflammation in the anterior chamber, so that will help from a pain control standpoint. And then again, most of these cases end up going as outpatient. All right. All right, who wants to read this question?
Which of the following management options is appropriate?
Yeah, perfect. So applying, again, that cyclopentolate or cycloplegia agent in consult with ophthalmology, who may also recommend steroids as well, but they, again, should have opto evaluation. Ruptured globe, yeah, perfect. So ruptured globe. So if you don't get anything else out of this lecture, what I would say is rule out a ruptured globe, number one. If you do pick up a chart that is concerned for an eye injury or an ocular injury, you always want to rule out an open or a ruptured globe. And then after that, you can kind of figure out the extent of the injury associated with it. But number one, you always want to rule out a ruptured globe. And so like they said, teardrop deformity towards the penetrating foreign body. And then you see an eyelid laceration as well associated with it. So you will see eyelid lacerations, kind of a general theme with the history in the physical exam, as well as the management associated with ruptured globe, penetrated globe, and then as well globe lacerations. But these are kind of the key histories, and more so from a board standpoint. I don't know how often pediatric patients do hammering metal or grinding metal, but so you will see this as part, maybe a workshop at school or something. But so the fragments that shoot off and cause penetrating eye injuries, that's why it's associated with that. But any significant trauma or significant decrease in the visual acuity, and anyone that has just a difficult exam, so significant swelling, pain, that would be one that you would be even more worried about a potential ruptured globe. So key findings on physical exam. So we talked about the characteristic teardrop pupil, again pointing to the penetrating foreign body, but also mass extrusion, so intraocular contents that are being pushed out or coming out. You don't want to mistake this for a foreign body or try to mess with it or try to remove it. If it looks pigmented, fleshy, mucoid, then that would be a concern for ruptured globe, as well as significant conjunctival hemorrhage that is surrounding the eye, large hyphemas. This is also something that you would be worried about. And then any displacement of the eye. So not proptosis, or even with proptosis, but posterior displacement of the eye, you would also be worried about as well. So when you're looking for that asymmetry, not just outwardly, but also inwardly, if it's pushed in, if it's pushed in, is something to think about as well. So one exam that you could do with fluorescein is a Seidel test. So with small penetrating foreign bodies or lacerations, they can self-seal on their own. So if you have a negative Seidel test and you're worried about a penetrating foreign body, that doesn't rule out a ruptured globe. So it's just something to keep in mind. But if it is positive, you will see leaking of the humor of the liquid within the eye. So you'll see it, running down the eye with your exam. One thing that ophthalmology, as well as whenever you do a slit lamp exam, you'll see a shallow anterior chamber from that standpoint. So ruptured globe, key management. If you're worried about it, stop the exam and avoid any agitation, anything that increases intraocular pressure. So vomiting, screaming, yelling, fighting, and this is kind of pediatrics in general, right? So stop the exam, get ophthalmology consulted early on. Rigid eye shield will help, and again, not a patch, because you want to avoid pressure on the globe. You want to make sure that it is overlying the bony ridges of the eye. And then again, you want to limit the activity, elevate the head of the bed, and then treat any associated pain or vomiting. Oftentimes these kiddos, especially with the mechanism, will get a CT of the face and the orbit to make sure there's no other injuries, no orbital hematoma, no intraocular foreign body. And then you want to consider their tetanus status as well as IV antibiotics. Oftentimes it is recommended to start IV antibiotics. Again, you'll talk with ophthalmology, but the typical recommendation is Vanc and Ceftaz because of the risk of internal eye infections, so endophthalmitis. There's significantly poor prognosis associated when that does occur, and so you do want to cover that prophylactically. And so over 50% of the positive cultures that have been associated with this have been either bacillus species or coag-negative staph. So those antibiotics would cover it, but other strep, other staph infections, and even mixed flora, gram-negative organisms can also occur in these scenarios as well. So complications, we've already talked about it as well. Endophthalmitis, an incidence of anywhere from 2 to 7%, but you could also see other injuries associated with it, scarring, cataracts, and retinal detachment. So similar to a HyphemA, hypopyon, so it's just layering of that leukocytic infiltrate of that pus in the anterior chamber. So you may see that as well associated with ruptured globe endophthalmitis. Okay. Yep, so apply an eye shield, exactly. And so concern for globe rupture with a teardrop pupil, you want to stop the exam. Keep the patient as calm as possible. Again, not an eye patch because you want it to lay over the bones, not the globe itself. And then I know this is going to be trivial, but if there's a foreign body in the eye and it's sticking out, don't try to be a hero and take it out. Just leave it in place. And then obviously talking to ophtho and the IV antibiotics and tetanus that we talked about. Okay. Last visual case. We're wrapping up here. So this patient comes in, worried about eye injury, and then you try to have the patient look up. This is what you get. What are you worried about? Yep, perfect. Orbital fracture, so orbital wall fracture. Specifically the inferior orbit, because you have entrapment, so restriction of movement from the inferior rectus muscle, so they're not able to look up with that eye. So orbit fractures, and that's your posterior displacement, Irwin. So one of the orbit walls that is involved, typically the most common is the inferior wall and the medial wall. So with that inferior, you'll get entrapment of the inferior rectus muscle. It's rare to have a lateral wall fracture. Something to keep in mind, though, as well, whenever the bridge of the nose is also hit with significant trauma, something you also want to consider is, could there be an medial orbital wall fracture associated with it, or an inferior orbital wall associated with it? So typically those kids will get a CT craniofacial, but that will kind of rule out both not only a nasal fracture or nasal injury, but also the orbit itself. Superior walls that are involved, you worry about intracranial process, so leading to infection intracranially and abscess, meningitis, etc. So things that you might see with the superior wall is CSF rhinorrhea that's coming out. And then we talked about the entrapment. Tends to be adjacent to the fracture site, so depending on their restriction of eye movement will indicate kind of which muscle is involved and which wall is involved as well. The exam, again, can vary anywhere from restriction, asymmetry, to displacement, either outwardly or posteriorly. So endophthalmos, not exophthalmos or proptosis. You could also see crepitus or feel crepitus with any orbital emphysema that's associated with it. Step-offs. Those are something as well, too, that you might see. Afferent pupillary defects with traumatic neuropathy. You might also see that as well on exam. So again, doing the swinging light test and looking for a Marcus gun pupil associated with that. You want to avoid blowing the nose. This will only increase elevated intraocular pressures as well as cause orbital emphysema associated with it. And then ophtho-consult. So one of the common pitfalls is just ruling out other eye injuries. There has been another ocular injury associated with it about 20% of the time when you do have orbital wall fractures. So you definitely want to have ophtho come in for these patients and rule out other injuries. And then antibiotics and steroids. There's limited data regarding both of these. Kind of two small trials for steroids, and the theory is that with muscle restriction or entrapment, it helps reduce with the swelling, and so it may help from that standpoint. Antibiotics, the thought is if it involves a sinus, then you would want to cover with antibiotics such as Augmentin or Azithro in that clinical scenario. But again, limited data associated with that. CT indications, so if there's an obvious fracture on exam, so you feel crepitus, you feel a step-off, there's restriction of the extraocular movements, or if the significant mechanism is associated with any of the following, so decreased visual acuity, severe pain, inadequate exam because of the soft tissue swelling, you're just not able to get a good enough exam or open the eyelids, and if there's any altered mental status. Craniofacial specialist for definitive management, especially associated with the fractures, would also be another specialty to consult. Yeah, A. So hypoesthesia of the right cheek, I didn't talk about this, but because the inferior wall is more commonly fractured, you do have an orbital nerve that is along that ridge there. So when you do have a fracture, you could have injury. So you could get numbness to that right cheek, to that area. That by far is more common than other intraocular injuries or globe rupture. But it just, again, you also want to rule that out, but that tends to be more common. And then you see blood in the maxillary sinus. So going back here, you see the maxillary sinus here where the fracture is, and you see blood in there. So that with a mechanism, with the associated trauma, it is likely blood and not an infection like a sinusitis or something like that. So real quick on ocular compartment syndrome. So again, associated with trauma, hemorrhaging along the inside of the eye. and having significantly elevated intraocular pressure, where you have hardening of not only the eyeball itself, but also tension and hardening of the eyelids also. This is a clinical diagnosis, but this is also where you worry about optic nerve involvement. So you can see an afferent pupillary defect associated with this because of pressure as well as ischemia associated to that optic nerve. And so with the exam, you could see all the things that we already kind of talked about with trauma, but specifically the rock hard eyelids will be kind of one of those lines that you'll see for like a board exam kind of question. And then also decreased retropulsion. I don't know why you would do this, but the thought is restriction when you're trying to push the eye deeper into the socket. That is one of the kind of common presentations on exam that you will see as well. So this is a true emergency. This is where you would want to do a lateral canthotomy along the eye, as well as an inferior cantholysis. And this procedure should not be delayed for imaging, so waiting for a CT. If you're worried about ocular compartment syndrome, this is one where you would just do the procedure and then get the CT or the imaging done later. If ophthalmology is in-house and can come quickly, then that also can be an option. But and we'll kind of briefly go over the procedure here. Other things that you want to do in terms of treatment, so similar to other things that we've kind of talked about, elevating the head of the bed, pain control, antiemetics, and then you want to control for BP or assess for any underlying coagulopathy that might be contributing from a pressure standpoint. So real quick, the lateral canthotomy procedure. So you're going to inject lidocaine into the lateral aspect, 1% with epi, and then you use a hemostat to end up putting pressure and leaving it clamped down about a centimeter or two to devascularize the tissue. And then you want to leave this in place for at least a minute. And then take it off with blunt scissors. You want to cut it, and that'll help to open up that space. With forceps, then you're going to grab the lower eyelid, retract it down to be able to expose that inferior tendon that you see depicted here by the yellow line. And then with the scissors pointing downwards, you're going to want to cut that inferior tendon. And that's the inferior cantholysis portion. With this procedure, so symptoms should improve as well as intraocular pressure should also improve as well. So if that's not the case, then what you could also do is cut the superior one that depicted by the yellow or by the green lines there. You could cut that upper canthal tendon as well. Okay, so real quick, these associations, left to right, which one is CSF rhinorrhea associated with? Yep, orbital fracture, specifically the superior one, diplopia. Yep, lens dislocation. Oh, sorry. Photophobia. Phobia, iritis. And then, yeah, flashes of light with retinal detachment. Real quick on retinal detachment. So you could see flashes of light, and the retinal detachment tends to be on the periphery. So if you do a fundoscopic exam, you may not see it. But with the flashes of light, it's because of tension on that retina from that standpoint. You could also see floaters, and that's because of fibrous aggregates in the posterior of the eye. And so that's why the patient may report seeing floaters because of that reason. You want to get optho involved if there's any concern for retinal detachment very early on, because the worry is progressing from partial detachment to complete detachment is something that you want to try to avoid. And here are the indications for emergent optho consults. So ruptured globe, concern for ruptured globe, and an uncooperative exam, vision loss related to trauma, involvement of the extraocular muscles, HyphemA, you can see the list there. And then complex eyelid lacerations like we talked about, or severe chemical burns. Common pitfalls, so always remember you want to rule out a ruptured globe, especially even if you only see a superficial injury. You always want to consider, am I missing something else, or could there be a ruptured globe associated with whatever else looks more superficial? The other thing is, similar to other things, when a kid comes in with after a trauma, a fractured leg, or whatever the case may be, is not just focusing on that one thing. Even though they may have an eye injury associated with it, you also want to make sure there aren't any other life-threatening issues that are going on. It's so easy just to get pulled to one isolated thing, but also always to keep in mind that you want to treat the life-threatening injuries before the even though it is present and it is important, ends up being less serious eye injury. And then examine both eyes. Questions?